How do you handle someone with a hiatal hernia? I don't know. I don't have anything special. People do like visceral things where they pull the gut, like applied kinesiology people, they have a patient breathe in and then they pull it down, and then they work on their core abdominal muscles. I mean, that would be something to do, to consider it. But I got to tell you, I haven't treated hiatal hernia in my 20 years directly, so I don't have any experience. Okay. How does mast cell disorder interplay with gut healing? So mast cell disorder is another one of these big things that gets overlooked, okay? So my entire goal of teaching neuroinflammation first is because the glial priming gets overlooked. It's a major issue with chronic patients. Autoimmunity gets overlooked. That's why we're talking about that next and how to treat it. Mast cell activation syndrome is a serious thing, okay? And many people suffer from it. And, there's lots of papers on it. At the end of the day, you're trying to decrease exposure. You can do things like high amounts of quercetin. You can use things like DAO to help break down that. You can use things like butter bar or natural antihistamines to calm it down. But at the end of the day, you're trying to improve their immune tolerance. That's still a key thing. We're going to talk about that in the next module. But immune tolerance is a key pathway. And there is some reduction of patterns there, and they are hard to treat. There's different degrees of mast cell activation. Some are really complex and really hard to treat, just like autoimmunity. You do everything you can and nothing helps. And some are really easy to treat. There's a whole spectrum of them. But I don't have like a complex protocol to share with you other than try to break down histamine, get it out of the system, reduce sugars, and improve their immune tolerance. Okay. Do you ever use binders with endotoxemia? You can do that. But it's not going to really make much of a difference. So there's different types of gels and binders people use for infections and parasites where they ingest them. Some online. There are things like charcoal, but various types of binders. And if they kind of bind to pathogens, but with endotoxemia, it's in the blood. It's not just in the gut. It's already systemic. So I doubt you would get any significant change with them. Those are good for an acute infection in the gut to use some binders, but not necessarily with endotoxemia. Okay, next question. Do coffee enemas affect the gut microbiome? Well, of course, they impact the gut microbiome. But don't forget, coffee is loaded with flavonoids. They're powerful antioxidants. And I think coffee gets a bad rap. Okay. I mean, of course, you don't want to use it with hypertension. Some people can't handle stimulants, but coffee causes contraction of the gallbladder, causes motility activation, has lots of antioxidants, has been numerous studies now link it with slowing down neurodegenerative diseases. So I think the benefits of the microbiome are positive, but I haven't read any direct paper studying coffee on the microbiome. I would only guess it'd be positive, okay? What is the difference between beta-hydroxybeta, methyl-butyric acid, beta-hydroxybutyrate, and butyric acid? These are all the things people are using for ketosis and converting people into ketosis. These are fatty, medium chain and short chain fatty acids that they're trying to use to convert it. So they're all different versions of the same thing. The butyric acid, short chain fatty acid, and oxybutyrate, or just who's using it. People in the ketogenic world that are trying to make powders and drinks to get people into ketosis faster are using the first two. And people in the microbiome world, gut world, autoimmune worlds are just using butyric acid. They're going to convert back and forth. Most of the research on the gut and microbiome is just with plain butyrate, not these other versions that have to be metabolized. So that's how you'll see them in the industry. As far as which one's more accurate than the other, I think they're going to have commonalities and metabolism to each other. So I can't go deeper than that. Okay, next question. If most antibody markers on array 12 are positive or equivocal, is that suggestive of active infection that needs antimicrobials or an overzealous Th2 immune response that needs Treg support? What if CBC is normal or with normal or low white blood cells? So we didn't talk about array 12. Array 12 is a Cyrex panel that has a screen for pathogens, but they're pathogen antibodies. And pathogen antibodies just means exposure. So not all exposures cause active infection, okay? So let's see what they're saying. They're saying most of these are positive. Now, when most things are positive with pathogens, sometimes you have polyreactivity. Sometimes you do have an active infection that's going on. Your biggest clue is the white blood cells. But here they're saying, what if there's normal or low white blood cells? Then you see that with autoimmunity, you could immune overzealousness. You'd have to probably do a T and B cell profile to see what's going on. And there's just times people have been exposed to multiple pathogens, but they're not really there. RA12 is a good screen, but it's not a test that really tells you if there's any active infections. It's just a screen. But sometimes the screening gets you more confused than it helps you. And it's the least common profile I do because of that. Because it also freaks out a lot of people when you just test all these pathogens, they got exposure, they think they're like dying of every disease out there, but it's not. So I think I don't have a good answer for you other than just do your workup. If you do more than just the antibody panel, look to see if you see other symptoms, other clinical presentations, dig deeper. If you really suspect there could be an active infection, then the key thing to do is a T and B cell profile. If the T and B cell profile is normal, there is no active infection. These are all past exposures. T and B cell profiles, in the point where the helpers are up and suppressors are down, there's a pathogen, and it's one of the ones on the list are possible. So that's what I would do. Okay. Is a positive nasal swab Marcone test clinically significant, or is it simply normal flora? I don't have enough experience to answer that, so I'm going to skip that one. Okay. Can zonulin be released by anything aside from gluten? Yes. What about foods that cross-react with gluten? So most of the research in zonulin has been done with celiac disease, and celiac disease aggressively releases zonulin. But anything that causes some degree of insult to the gut can cause some zonulin release. It doesn't have to be gluten. So you'll see many of those papers that were published with various studies where they looked at zonulin. Those were not on celiac disease patients. So zonulin is triggered by an immune inflammatory response in the gut, but it causes paracellular breakdown. So it's not specific to celiac. Celiac, the key feature of celiac is that it releases T cell destruction in conjunction with zonulin. Okay. Are tissue transglutaminase complex antibodies less severe than the 3 isolated transglutaminase isomers? Oh, transglutaminase complex, I think what they're asking is transglutaminase complex. There's a marker on array 3 where they look at gluten plus transglutaminase complex. And that is a way to find gluten reactivity. So there was a paper that was published that showed if they measure gluten antibodies alone, they miss some patterns of gluten sensitivity. If they measure transglutaminase alone, they miss some patterns. But when gluten binds to the transglutaminase complex, you find hidden sources of gluten sensitivity. So that's just a marker to find hidden source of gluten sensitivity. The actual transglutaminase isomers, 2, 3, and 6, are self-tissues that are telling you where the autoimmune attack is happening. 2 is to the gut, 3 is to the skin, and 6 is to the brain. So they're just different tests altogether. Okay, next question. What is your opinion on the use of mediator-released testing versus antibody testing? Oh, it's junk science. Don't do it. It's a total waste of money. I mean, basically what they're doing is they're seeing if the immune cell swells up. So what? Means nothing. One of the things we'll do next modules when we talk about autoimmunity is all the different types of food testing. MRT it's not even allowed in many states because they can't reproduce it. If I saw a practitioner do MRT, my first clue would be, you have no idea what you're doing. And I think some patients, if they read up on it, will feel the same thing. Okay? Just because a lab is invented and has a brochure doesn't mean the test is a good test. Okay? No, not a big fan. I was trained that antibody testing is not valid for screening food sensitivities. That is absolutely incorrect. I can tell you one thing. So my PhD work was in immunology. If I went to my RV review board and said, I want to do MRT for my thesis, they would laugh at me. They would go, why would you do an invalid test? Justify the use of this test. And there's no way, because there's no way immunologists are going to pick a test like that as a valid test for food antibodies. Okay, next question. Do you ever prescribe an IgG product, or if not, or yes, why? So some manufacturers make immunoglobulin products to support them. I haven't used them a lot in my practice. I have some of my friends that like to use them. They have mixed outcomes. So I think for some patients they may work great, but I personally don't have a lot of experience using them, so I can't comment past that. Next question. Can you speak to considerations for women in perimenopause? Is there anything different in our approach to the GI workup for these women? Do we stabilize hormones first or treat gut first? Well, that's a good question. You know what I would do? I'd ask the patient, where do you want to start? They're like, I'm going to kill my family and my kids and you if you don't help. Let's start with your hormones. Right? I mean, what do you do? Okay. I can't eat anything. Let's start with your gut. You go either way. I mean, a lot of times when you have vicious cycles, you don't know. You may do both, but just know that if like it is intestinal permeability and hormones are fluctuating all over the place, it could impact it. And when hormones fluctuate all over the place, you can get overactivity of the immune system. So a lot of times you're just like, get through it. Get through it. Your immune system is going to totally change. Your gut's going to totally change. Maybe you put them on different phytoestrogen compounds, natural compounds, to getting through it. You support the detox pathways, you support their adrenal glands, stabilize their blood sugar, get them to kind of get through it smoothly so there's not these ups and downs. Maybe at the same time you can complement the protocol with treating their gut or kind of working that way. But, you know, it's a choice you have to make as a clinician with the patient and what they present with, okay? You can go either way. One way doesn't work, you can switch, okay? Is butyrate alone okay, or do you need to supplement all 3 short-chain fatty acids? There's studies that just use butyrate by itself. Butyrate is just fine. I like the combination of all 3, but butyrate is a good source by itself, so you don't have to use all 3. But there's just some studies that just use butyrate, and there's others where they use a combination approach, but butyrate is the key marker, okay? Next question. For some unresponsive issues, do you recommend IV nutrient therapy? So yes, we didn't talk about this, so this is a great question. For people that do have malabsorption syndromes, you have to use IV therapy. If their microvilli is gone, you have to use IV therapy. And if you see preglobulin levels low, you gotta use IV therapy. Preglobulin levels abnormal, low is actually what they are. You have to use IV therapy. People that have pernicious anemia, B12 shots can be helpful. You can try to use sublingual, but by the time they get B12 pernicious anemia with intrinsic factor antibodies, it's really hard just to use sublinguals to get their levels back up. I mean, you can try, but they really do better with just some B12 shots until they get their anemia under control, and then you can try to use sublinguals too. But when they're totally anemic, you might need to just get their levels up quickly, okay? What type of IV therapies are most effective in your experience and how often? Well, I don't do IV therapies with my scope of practice being limited to not be able to do them, so I don't have any experience. But usually, most people that do them have their cocktails, Myers cocktails, and various things, and that's the basic approach, okay? And just like anything else, there's people that do all different types of bags and make their own little versions, and some who just use Myers cocktail. So it really depends who they see, but I don't have clinical experience making IV therapy treatments for my patients, okay? I do refer out to people that do it, but they're doing just basic routine stuff. Okay, are other sensitivities like salicylates or microbiome issues more of a dendritic APC issue? I don't know. Can't answer it. What branch of the immune system do lectin foods activate? Ooh. Do they activate complement? Yes. Will this result in a lower test result of C3? No. It's been activated to C3A? No. This would be a good test for lectin sensitivity. It's not specific, but you can't test it. So you guys know what complement proteins are? We're going to talk about this next course. By the way, the autoimmune course, the first few hours is immune function from every cell and every mechanism, every action, and how it can dysfunction, okay? Because you can't treat autoimmune unless you own immunology, okay? So we're gonna really cover immunology in depth and then start talking about how it breaks down, how it overacts, how it dysfunctions. Because same with autoimmunity as with GI, you don't jump into protocol. You go through the mechanism, you think through it, you figure it out, you take a step back, and you then try to activate mechanisms, okay? So the complement protein is a mechanism. So complements are like minefields throughout the immune system, because your T cells, your B cells are there to find and scavenge things, but throughout your immune system you have these little landmines, and if they get activated by pathogens, the complement proteins will be elevated. It could be CA, 3A, it could be any of the complement proteins that happen with lectins. Any pathogen can raise lectins. Mold toxicity can raise lectins, so it's not specific, but when people do have lectin immune reactivity, they'll see a key issue. Now, you know what the best mechanism is to tell you if you have, so lectin is part of what's a mechanism called agglutination. Agglutination proteins stick together, and by sticking together, they change. That's what lectins do. Lectins are sticky. They all start sticking together, and they change, they become neoantigens. That's what rheumatoid factor is. Rheumatoid factor is IgG and IgM agglutinating together. So if you ever see rheumatoid factor and complement proteins activated, you definitely start thinking lectins could be a big, big issue. We just did a data analysis of a study of 400 subjects where we checked food proteins and lectins to 24 autoimmune diseases. And what we found was not every single autoimmune disease has a reaction with lectins. For sure, the rheumatoid joint have a significant reaction to lectins. Of this 400 sample population we did, thyroid disease, nothing almost. As far as the data set we got, that it wasn't necessarily a lectin thing. So I think things that where agglutination is more of an issue is going to be more of a lectin problem, but that's still exploratory. Okay? Next question. Is directly stimulating the vagus nerve with exercises, gargling, etc., contraindicated in Parkinsonism because it may drive the disease mechanism further? No. If so, is vestibular stimulation also contraindicated due to its activation of the vagus? No. With any kind of unstable neurodegenerative issue, I think what the question is trying to ask is can you overstimulate? And the answer is, well, yes, okay? But it's not contraindicated. So with any neurodegenerative neuron, they're unstable. So if you stimulate them, you can overactivate, you can make a person crash, okay? But typically with Parkinsonism, these things, they don't make the patient worse. Like most people can handle lots of gargling, vestibular input, maybe that's an issue. The only way you know if overstimulation is an issue is if they get worse when you do it. And then you have to back off. Like with Grace, acetylcholine made her nauseous and want to throw up. Dopamine caused her to have mood changes in dopamine support to activate natural dopamine agonists, totally made her fall apart. So those are unstable. We can't push that with a neurochemical approach. So we have to back off. Now, you know what I told her, I forgot to say, when we discussed her case. I told her to take her acetylcholine support and dopamine support and put it in the freezer, because as we get her brain healthier, I want her to challenge herself with it again. And then if she challenges herself again, then I can see if she's more stable now. So you can push a neuron chemically past its metabolic rate, and you can do it with stimulation. So I think that's what this question is trying to ask. Okay? And let's go to this next question here. Patient has elevated propionate, fluttering in the abdomen, and anxiety. Why would the propionate be high, and can it cause symptoms? Does high propionate promote autoimmunity? I have no idea what this is asking, so I'm going to skip. Okay. Have you had any issues in your patients with high TGF-beta blood testing? Well, if you have high TGF-beta, that's awesome. TGF-beta, if you're measuring it, is your key mechanism to turn on Treg cells. So you want this TGF-beta to be high. So I don't know if I had any issues, but if I saw a patient with high TGF-beta, I'm going, they're kicking in their Treg cells, and that's a state of really healthy immune function. Okay. Last question here. How would you expect to see eosinophils with parasite versus allergy? So if eosinophils go up with both, you don't really know unless you dig deeper into the allergies. If they are allergies, you'll usually see wheezing in the lungs. They'll tell you when they get exposed they can't breathe. There'll definitely respiratory issues involved with allergy-induced eosinophil elevations. And whereas the gut, you don't see those symptoms and you suspect the gut. So that's the main way. Anyways, Thank you all for coming, and then I'll answer the rest. Thank you. Thank you.